We're going to go over Chapter 16 today, Respiratory Emergencies. National EMS Education Standard competencies are found on the very first page of the chapter in your textbook. I'm not going to go ahead over these first 5 slides because we're going to cover them a little bit more in depth as we continue on. One of the calls that we most often encounter is going to be complaints of dyspnea. Dyspnea is shortness of breath or difficulty breathing. It can be caused by multiple conditions. It's not necessarily important or as important sometimes to know what is causing it. It might be difficult to figure that out, but we can always treat the patient. Even if we don't understand exactly what's causing their dyspnea. We're going to go over a brief overview of the respiratory system. Some of the structures involved are going to be the diaphragm, your chest wall muscles, the accessory muscles of breathing, nerves to the muscles. You've got your upper airway, which consists of structures above your vocal cords or your larynx. That's going to be your nose and mouth, your jaw, oral cavity, your pharynx, and your larynx. Your lower system is going to be your trachea, your bronchi, your alveoli. The function of the lungs is for respiration, which is the exchange of oxygen and carbon dioxide. Your air is going to travel through your trachea into your lungs and then into the bronchi, the bronchioles, and the alveoli. The alveoli is where the gas exchange actually occurs. We have 2 processes that occur during respiration. We have inspiration and expiration. During that process, we have oxygen is provided to the blood, carbon dioxide is removed from it. In healthy lungs, this is going to take place very quickly at the level of the alveoli. This is the physiology of respiration, shows the exchange of oxygen, carbon dioxide within the alveoli. Then we've got in the alveoli, they're lying against the pulmonary vessels, the pulmonary capillary vessels to be specific. Oxygen is able to pass through tiny passages through the alveolar wall into the capillaries through the process of diffusion. Diffusion is going from a higher concentration to a lower concentration until they're about equal. Once that occurs, the oxygenated blood is carried to the heart through the pulmonary veins and then is pumped out through the body, through the aorta and the arteries. Carbon dioxide is returned to the lungs through the pulmonary arteries and is exhaled after that diffusion occurs again at the alveolar and capillary. Your brainstem senses the level of carbon dioxide in the blood. If it senses that the carbon dioxide level is too low, it's going to have the person breathe at a slower rate and less deep. If it senses that it is too high, they're going to have that, it's going to cause the patient to breathe quicker and more deeply. So it's at the brainstem where that breathing is regulated. Some of the things that could cause the oxygen exchange to be impaired or hindered is if there's an issue with the anatomy of the airway, if there's some sort of disease process, infection, inflammation, some traumatic conditions, or if there's abnormalities in the pulmonary vessels such as a pulmonary embolus. We want to recognize our signs and symptoms of inadequate breathing, and we need to know how to treat it. Okay. Carbon dioxide retention and the hypoxic drive is what I was discussing just a little bit ago, a couple slides ago. Your patients sometimes have that elevated level in their blood. If it stays that way for an extended period of time, the body becomes used to it. It adapts and accommodates those high levels of carbon dioxide. So instead of taking a breath on because of the high levels of carbon dioxide, it triggers the body to take a breath based on low levels of oxygen. This is our hypoxic drive. When we have patients with this condition, we want to use caution when we give them oxygen. We never want to withhold it. We just want to be aware that there is the potential that we could knock out their respiratory drive and we would need to ventilate them. So some of the causes of dyspnea or hypoxia could be some of the signs that they may have dyspnea or hypoxia can also be altered mental status. Causes could be pulmonary edema, hay fever, pleural effusion, obstruction of the airway, hyperventilation syndrome, environmental or industrial exposures, drug overdoses, gas exchanges obstructed between the pulmonary circulation, whether there's fluid in the lungs, infection, or collapsed alveoli. If the alveoli are damaged, they may not be able to transport the gases properly across the walls. We can have spasms in the muscles of the airway. We can have weak, floppy airway walls. There could be an obstruction of blood flow, such as a pulmonary embolus, or we can have excess fluid or air in the pleural space. So what are some of the signs and symptoms? Patient is telling you that they're having shortness of breath or difficulty breathing. They have an altered mental status associated with shallow breathing or slow breathing. If the adult patient appears anxious or restless, or the pediatric patient appears sleepy or listless, you're having a hard time keeping them awake. If they're breathing too fast or too slow, if they're breathing irregularly, if their skin is pale, cool, clammy, or cyanotic, adventitious breath sounds could be heard, wheezing, gurgling, snoring, crowing, or stridor. Please remember, stridor is the only upper airway noise we have. Then we can have decreased or noisy breath sounds heard on one or both sides of the chest. Patients not able to speak more than a few words between breaths. If you're asking the patient how they're doing and they can't speak at all, you need to consider that a respiratory emergency. If they're speaking in 2 or 3 words, we call that 2 to 3 word dyspnea. That is a bad sign. You want to make sure you get them on oxygen, try and figure out what's going on, why they're having difficulty breathing. If they have unequal or inadequate chest expansion, if they're using accessory muscles, retractions, labored breathing, if they're sitting up, leaning forwards with their hands on the bed or on the arms of the chair, we call that a tripod position. The back and both arms are working to support the upper body. If they have pursed lips or nasal flaring, these are all signs or symptoms of inadequate breathing. They could complain of chest tightness or hunger. Dyspnea is common when we have our patients with cardiopulmonary disease. An example is congestive heart failure. In this case, the heart is pumping inefficiently and it's not adequately providing the body with oxygen. We can have severe pain, can cause rapid shallow breathing. If they have an injury to their chest, they're not going to be taking those full breaths possibly. So you want to look about that and think about that as well. So We can have upper or lower airway infections causing dyspnea. It's going to affect all parts of the airway. Oxygenation is a problem because of inadequate oxygen delivery to the tissues. It could be an obstruction. So we could have mucus and secretions obstructing the airflow into the major passages. We could have swelling of soft tissues in the upper airway, such as what we see in epiglottitis or croup. Or we could have impaired gas exchange, like we see with pneumonia. You want to be cautious and be aware to make sure that you use the proper PPE when you have patients that have infectious diseases. So the first one we're going to talk about is croup. This, we're going to see the patient has been not feeling good for a couple of days. They've got flu-like symptoms. It's getting worse. They're going to have inflammation and swelling of the larynx, pharynx, and trachea. They're going to have stridor. They may have, or they will have, a seal-like bark. It actually does sound like a seal when you hear them. We generally are going to see this in children between about 6 months and 3 years old. Usually they're going to have relief with humidified oxygen. It used to be if you would call your pediatrician and the child had croup, it was after office hours, they would tell you to take the child into the bathroom, turn the hot water on in the tub and in the sink, close the bathroom door, and fill the bathroom up with steam, and let the child breathe in that steamed or humidified oxygen. And it would help soothe it, and then you would bring them in the next day to see the pediatrician. Now we've got epiglottitis. The difference between croup and epiglottitis is epiglottitis usually is going to be quick onset. They're going to have a fever. They're going to have an extremely sore throat. They're not going to be able to swallow well. They're going to be drooling very severely. This is usually seen in children. Every once in a while we'll see it in an adult. What it is the epiglottis, that little flap, that leaf-like structure that goes over your trachea, becomes irritated, infected, inflamed, swollen, and it's not working properly. You want to make sure that you do not attempt to suction these patients. We do not want any irritation. Do not make them cry. Keep them nice and calm. You can put high flow oxygen on them to treat, and rapid transport. With respiratory syncytial virus, or RSV, used to be this was mainly seen in young pediatric patients. We're now starting to see it in our older adults and people with compromised immune systems. It is an infection in the lungs and the passages. It is a virus, not a bacteria. It's going to cause irritation and difficulty breathing. It may lead to bronchiolitis and pneumonia. You're going to look for signs of dehydration. It is extremely contagious. You're going to treat their airway and breathing problems. Humidified oxygen does sometimes help. Bronchiolitis is something that we often see in newborns and toddlers caused by RSV. The bronchioles actually become inflamed. They swell and fill with mucus. We're going to go ahead and give them oxygen therapy. We're going to be reassessing them frequently for signs of respiratory distress. We have our pneumonia. We have two different types. We have bacterial or viral. Bacterial pneumonia is going to have a sudden onset. There's our OPQRST, right? How to onset. It's going to be sudden. It's going to have a high fever. Your patient is not going to want to do anything. They're just going to be feeling very drained. It's an effort to do anything. With the viral pneumonia, it's less severe. It comes on more gradually. Your patient may just be doing their normal activities of daily living, just really feeling lousy, but still able to keep going. Sometimes it's called walking pneumonia. It's often a secondary infection that began after an upper respiratory tract infection. It affects people a lot of times who are chronically or terminally ill or have a compromised immune system. You're going to get their temperature, provide airway support, and give them oxygen. With pertussis, it's an airborne infection. It's usually going to affect children who are less than 6 years old. Your patients are going to have a fever, and they're going to have coughing attacks or coughing jags. And afterwards, they're going to make a noise as they're trying to suck in air, because during those coughing jags, they're not able to get in a breath. So when they do, it's like a whooping noise, which is where it gets its name whooping cough from. It is very contagious. It's passed through droplets. You want to watch for dehydration and consider suction. We have our influenza type A. It was a pandemic back in 2009. It was an animal respiratory disease that mutated to infect humans. It is transmitted through direct contact with basal secretions and aerosolized droplets from coughing. Signs and symptoms include fever, cough, sore throat, muscle aches, headache, fatigue. We want to pay attention to our patients. It could lead to pneumonia, and you always want to evaluate them for dehydration. With COVID-19, it's a coronavirus similar to one that causes the common cold. It affects most commonly the elderly patients, patients living in close quarters, such as in a nursing home, if you have a weakened immune system. However, it can also affect young, healthy individuals. Okay, it's transmitted through aerosol droplets, airborne particles generated by sneezing or coughing, or by direct contact. The symptoms are going to be high fever, cough, inspirational chest pain, vomiting, diarrhea, and inability to smell. You want to monitor these patients carefully, because respiratory deterioration can occur rapidly. Then we have tuberculosis. It is a bacterial infection that is most commonly affecting the lungs. However, it can go anywhere, any other organ in the body. It can be inactive for years before any symptoms are produced. Your patient, when they do have symptoms, complain a lot of times of fever, coughing, fatigue, night sweats, and weight loss. It's more prevalent in homeless people, prison inmates, nursing home residents, people who abuse intravenous drugs or alcohol, and those with HIV. If you suspect your patient has active TB, you want to make sure that you're wearing your gloves, eye protection, and N95. You want to put a surgical mask on your patient. So with acute pulmonary edema, the left side of the heart doesn't remove blood from the lung as fast as the right side of the heart is delivering it. So it's building up within those lung blood vessels, within the alveoli, the lung tissues. It a lot of times is going to be a result of congestive heart failure. Your patients are going to have dyspnea with rapid shallow respirations. In a severe case, they may have a pink frothy sputum in the nose and the mouth. You're going to need to suction that. Okay. Most of these patients are going to have long-standing history of chronic congestive heart failure. Usually it's being kept under control with medication, and it's an exacerbation. Not all patients with pulmonary edema, though, have heart disease. This slide 16, figure 16-6 shows you the alveoli with the fluids in them. When we're talking about chronic obstructive pulmonary disease, or COPD, it is a lung disease that's characterized by chronic obstruction of lung airflow. It's going to interfere with normal breathing. It is not fully reversible. COPD is an umbrella term. It covers several different lung diseases such as emphysema and chronic bronchitis. Tobacco smoke can cause chronic bronchitis, which is an ongoing irritation of the trachea and the bronchi. With bronchitis, you have excessive mucus produced on a continuous basis, which obstructs the small airways and the alveoli. The airways are then weakened, and the protective cells and lung mechanisms that remove the foreign particles are now becoming destroyed. With chronic oxygenation problems, this can also lead to right-sided heart failure and fluid retention in your patients. They're more susceptible to pneumonia, and if they have repeated episodes of irritation and pneumonia, they can develop scarring in the lung and dilation of the obstructed alveoli. All of this leads to your COPD. Emphysema is our most common type of COPD. It's a loss of elastic material in the lungs as a result of chronic stretching of the alveoli. Smoking can directly destroy the elasticity of the lung tissue. However, not all patients with emphysema have it because of smoking. I'll give you the example of my father-in-law. He had emphysema, and yes, he did smoke. However, he also worked in a metal plating factory in the acid vat room, and he would breathe in the vapors from the acid vats. At that point in time, they didn't have as effective respiratory protection. So he developed emphysema as a result of the combination of the two. So patients that do have COPD usually are going to display symptoms of chronic bronchitis and emphysema. Figure 16-7 shows the bronchial and alveoli through the different disease process. Some of the differences between pulmonary edema and COPD is our patients with pulmonary edema, they're going to have what we call wet lung sounds, bronchi crackles. Our patients with COPD are going to have those dry lung sounds. They're going to have those wheezes. We should never assume that all COPD patients have wheezing and all congestive heart failure patients have crackles. You always want to treat your patient, not just the lung sounds. So with asthma, hay fever, and anaphylaxis, they're a result of an allergic reaction due to an inhaled, ingested, or injected substance. Sometimes we can't figure out what the allergen is. Asthma is acute spasm of the smaller air passages, the bronchioles, and it has excessive mucus production and swelling of the mucus lining of the respiratory passages. So their respiratory passages are getting smaller. They're getting more narrow. Usually it's going to affect children between 5 and 17 years. It's going to have that wheezing sound as the patient is trying to exhale through partially obstructed airways. An acute asthma attack can be caused by an allergic reaction to a specific food or some other allergen. It can also be caused by severe emotional distress, exercise, or respiratory infections. In its most severe form, that allergic reaction can produce anaphylaxis. So hay fever is going to cause cold-like symptoms after exposure to things like pollen, dust mites, pet dander. These signs and symptoms are going to be runny nose, sneezing, congestion, sinus pressures. An anaphylactic reaction, however, is a very severe allergic reaction characterized by swelling of the airway, dilation of the blood vessels all over the body. That's going to cause that edema, that swelling. It might be associated with widespread hives, itching, signs of shock, signs and symptoms similar to asthma. Their airway can actually swell enough that it is totally obstructed. Epinephrine is the treatment of choice in an anaphylactic reaction. Oxygen and antihistamines such as Benadryl are helpful. A spontaneous pneumothorax is a partial or total accumulation of air in the pleural space. In other words, we've got an injury to the lung, we take in a breath, and that's allowing air to escape the lung and go into our chest cavity. As we breathe, more air is going into the chest cavity. It is starting to compress that lung. Sometimes it can be caused by trauma, but it can also be caused by medical conditions, and that is called a spontaneous pneumothorax. When it's spontaneous, it can occur with a lung infection, allowing air to escape into the pleural cavity, and that as that occurs, your patient is going to become short of breath or dyspneic. It can also affect the lung sounds. They're going to be diminished or decreased. They may complain of pleuritic chest pain. If it's not treated, it can develop into a tension pneumothorax, which is a life threat. When we have a pleural effusion, that is a collection of fluid on the outside of the lung. It's actually compressing the lung and causing shortness of breath. It can be caused by irritation, infection, congestive heart failure, cancer. Your breath sounds are going to be decreased where the effusion is present, and your patient is going to tell you that they feel better when they're sitting upright. So with dyspnea, they can have a mechanical obstruction. If the patient is conscious or semi-conscious, if the patient is semi-conscious or unconscious, it may be the result of aspiration of vomitus or a foreign object or correct imposition of the head, causing the tongue to block the airway. If they were eating right before the onset of dyspnea, you always want to consider that it could be a foreign body obstruction, such as a piece of food. Figure 16-12 shows you the proper positioning, and it shows you how the tongue can obstruct the airway. With a pulmonary embolus, let's start with embolus. An embolus is anything in the circulatory system that moves from its point of origin to a distant site and lodges there, obstructing subsequent blood flow in the area. A blood clot. Okay. Simple term, blood clot. It can cut off the circulation completely or partially. It can be fragments of blood clots from an artery or a vein that break off and travel through the bloodstream, or it could be foreign bodies such as a bubble of air. That would be an air embolus. Okay. A pulmonary embolus is a blood clot that circulates through the venous system and lodges in the pulmonary artery. It is going to reduce the amount of blood flow to part of the lungs. Your signs and symptoms are going to include dyspnea, tachycardia, fast heart rate, tachypnea, fast breathing, varying degrees of hypoxia, cyanosis, acute chest pain, hemoptysis. If the embolus is large enough, it's going to cause complete obstruction of the output of blood from the right side of the heart, and it can result in sudden death. With hyperventilation, we're overbreathing to the point where our arterial carbon dioxide level falls below normal. It can be an indicator of a life-threatening illness. We always want to be aware of it and paying attention. Your body may be trying to compensate for acidosis, which is the buildup of excess acid in the blood or body tissues. It can result in alkalosis, which is a buildup of excessive base in our body fluids. It can cause symptoms of hyperventilation syndrome or a panic attack, including anxiety, dizziness, numbness, tingling of the hands and feet, painful spasms of the hands and feet. We call that carpopedal spasms. The decision of whether or not hyperventilation is being caused by a life threat or a panic attack should not be made outside of the hospital. We don't just assume. We're going to go ahead and transport and have them evaluated by the physician. So with our industrial or environmental exposure, we could be exposed to pesticides, cleaning solutions, chemicals, chlorine, other gases that are accidentally released and inhaled. Carbon monoxide poisoning. Carbon monoxide is an odorless, highly poisonous gas produced by fuel burning appliances and smoke. It is the leading cause of accidental poisoning death in the United States. People who have carbon monoxide poisoning complain of flu-like symptoms and dyspnea. Make sure that if you suspect it, you bring your patient outside, get them on high-flow oxygen by a non-rebreather. So when we get on scene, we're always going to make sure that we are using our proper PPE. We always need to consider the possibility of it being an infectious disease, toxic substance. If we have multiple people with dyspnea, we need to consider that it may be a airborne hazmat. Consider calling them in. If the nature of illness or mechanism of injury is in question, ask why 911 was called. You want to ask the patient or their family or bystanders questions. You should then be able to determine what is going on. You're always going to identify your immediate life threats. You're going to get that overall general impression of your patient's level of distress. How are they sitting? What is their age, or how are they positioned? What is their age? Do your AVPU. Check for your responsiveness. Ask them about their chief complaint. Assess their airway. Make sure that it is patent and adequate. You want to evaluate whether or not they are breathing appropriately. Look and think to yourself, is air going in? Is air coming out? Is the rise and fall of the chest the same with each breath? Is the rate adequate for the patient's age? When we're checking our lung sounds, we should do it the same way every time. You're going to check on the right and the left sides, in the front and in the back. Figure 16-5 shows the location of the auscultation for breath sounds. You're listening for normal breathing. You're listening for normal sounds. Abnormal sounds would include your wheezing, your rales, rhonchi, stridor. Normal breathing is actually quiet. We don't hear it. You're going to assess your circulation. What is my heart rate, rhythm, quality? What is my skin color, temperature, condition? Checking the perfusion by doing that. Do they have any bleeding? Are they any signs or symptoms of shock that I observe? Where am I going to take this patient? How quickly do I need to get them loaded up? Is it a load and go, or can I stay and play? I'm going to get into my history. I'm going to start asking them questions about their chief complaint. What has been going on? How long has it been going on? What has the patient done for it? And then I'm going to get my sample history. If my patient's unable to answer my questions, then I'm going to talk to family members or bystanders if there's someone else available. And do my OPQRST. Sometimes that's not really going to give me all my information, so we use the acronym also PASTE. This is specifically for patients with shortness of breath. The progression, associated chest pain, sputum, talking tiredness, exercise tolerance. Okay, talking tiredness refers to how long are they able to speak? You know, are they able to talk in a normal sentence, or are they in that 2 to 3 word dyspnea? With exercise tolerance, I'm not asking how many miles can they run. Are they able to get from their bed to the bathroom, or the bathroom to the living room to the kitchen? Or are they getting short of breath, walking short distances? Is that normal for them? Because as COPD progresses, that can become normal for them, that shorter distances get more difficult, they get more dyspneic with it. I'm going to do a more in-depth assessment of my body systems on my secondary assessment. I only do that after I've done my life threats and have treated them all. Use my monitoring devices. Treat my patient, so not just my machines, right? So we're going to look for signs of COPD. Is my patient over 50 years old? Do they have a history of lung problems? Do they smoke, or are they smoking? All right. Do they have tightness in their chest? Are they tired with constant fatigue? Their chest can have a barrel-like appearance. In other words, a rounded appearance. Are they using accessory muscles to breathe? Are they using, and do I hear abnormal breath sounds? Are they exhaling through pursed lips? When they're doing that, they're actually causing pressure to stay in their chest. They're keeping those alveoli open. Do they have clubbing or abnormal enlargement of their fingers? You're going to repeat your primary assessment. When we do our reassessment, we're going to start back at that general impression and go all the way back down our sheet. All right, we're looking for any changes in their condition. Any interventions that I've done, is it helping them? Is it making them worse, or is there no change at all? Do I need to consider positive pressure ventilations? Do I need to consider different airway management? Do I have them in a high Fowler, which is a fully seated position, a 90-degree position, or do I have them in a position of comfort? Can I assist them with their respiratory medications? I'm going to give them oxygen. If I need to, I can give them ventilatory support. If their mental status is declining, I can go ahead and use that bag valve mask device. If they're in moderate or severe respiratory distress, or if their depth of respiration is not adequate, if they're not getting enough tidal volume in. If they have a metered dose inhaler, I can contact medical control and make sure it's okay to give them the medication or assist them with the medication. I'm making sure that there are no contraindications. The respiratory medications that are used generally are going to relax the muscles surrounding the air passages in the lungs, leading to the dilation of the airways. Some of the side effects that we're going to see is going to be an increased heart rate. They might get nervousness or agitated or anxious. They may have muscle tremors. Medications from an inhaler. It's delivered through the respiratory tract into the lungs. When we have an upper or a lower airway infection, we can give them humidified oxygen if we have it. We don't attempt to suction or put in an OPA because we don't want to do anything that's going to irritate that upper airway, especially the epiglottis, especially if we're suspecting epiglottitis. You want to put the patient in a position of comfort, and we're going to do a rapid transport. You can go ahead and for the acute pulmonary edema, you're going to put them on 100% oxygen. You're going to suction as you need to, position of comfort. And I'm going to tell you right now, these patients, their position of comfort is going to be sitting up as straight as they can. They do not want to lie down. If you are permitted to by your protocol, and if your patient meets criteria, you can go ahead and put them on CPAP, and you're going to do a rapid transport. For our chronic COPD patients, you're going to assist them with their prescribed inhaler if permitted. You need to make sure that they are not overusing it. You're going to watch for any possible side effects. You're going to put them in that position of comfort, and you're going to transport them promptly. For asthma, you always want to be prepared to suction. Assist them with their prescribed inhaler if permitted. You want to make sure that you're paying attention and ready to give aggressive airway management, oxygen, and rapid transport. Then with our hay fever, usually you're not going to need to transport these. They're not normally going to need any kind of emergency treatment. If anything, you're going to go ahead and give them oxygen. If they're really having an issue, you may need to manage the airway, but generally it's going to be provide oxygen. Anaphylaxis, however, you want to make sure that you remove whatever is the irritant or the allergen. Give aggressive airway management, prompt transport. I would be calling out my ALS units because they may need to do more advanced airways than I'm able to. And then I'm going to contact my medical control and give the EpiPen if it's permitted. With the spontaneous pneumothorax, pretty much what you're going to do is put them on oxygen, transport, and monitor. The same thing with that pleural effusion. There's nothing we can do for either one of these. The fluid removal for pleural effusion must be done in the hospital. We're going to give them oxygen, and we're going to transport. With with an obstructed airway, if it's a partial obstruction, we're going to go ahead and give them oxygen, and we're going to go ahead and encourage them to cough to try and clear that obstruction if possible. If it's a complete obstruction, we're going to go ahead and do the abdominal thrust, and if they go unresponsive, we will do CPR, clear the obstruction, give them oxygen, transport rapidly to the emergency room or emergency department. For a pulmonary embolus, you must give them oxygen. There is no question. You're going to put them in a position of comfort. If they have hemoptysis, you want to be ready to suction. Remember, hemoptysis is coughing up blood. So you want to clear that airway, and you're going to transport rapidly. For hyperventilation, don't give them a paper bag to breathe in. Okay, you want to do your primary assessment, you gather your history, reassure your patient, give them oxygen, transport promptly. Try and get them to focus on their breathing. For environmental and industrial exposures, we need to make sure that the patient has been decontaminated. and then we're going to go ahead and give them oxygen, use adjuncts if necessary, and suction. For a foreign body airway aspiration, you're going to go ahead and clear based on age and provide oxygen transport. If they have a tracheostomy and it's dysfunctioning, you're going to put them in the position of comfort. You're going to suction to clear the obstruction. Once it's cleared, you're going to go ahead and give them oxygen. We're going to get a little bit more into detail with that trach in just a minute, I think. For asthma, you can give them blow-by oxygen. Blow-by oxygen is we're going to take either the non-rebreather mask and have the reservoir filled and give it to the patient. Usually it's going to be like a pediatric patient. Give it to them, let them chew on it. They're holding it up by their face. That's going to go ahead and get oxygen going by their nose and their mouth. Another way we can do it is take a plastic or a paper cup, poke a hole in the bottom, put our O2 tubing up into that hole, and let them chew on the cup. Again, it's the same concept. We can also go ahead and give it to their parent or caregiver, and they can hold it near their face. Blow by means it's blowing by their face. It's not actually sitting on their face. You can use their meter dose inhaler, the same as you would for your older patients, and this is what we're doing for our children. Cystic fibrosis is a genetic disorder. It's going to affect the lungs and digestive system. It's an excess production of mucus. It will predispose the children to repeated lung infections. Symptoms can range from sinus congestion, wheezing, asthma-like complaints. You're going to suction and oxygenate them as needed. And we covered the stoma and trach back in chapter 11, so I will not be covering that in this chapter. If you have any questions, please feel free to ask me when I see you the next time. Have a great day.